This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, my name is Gordon Smith. I'm a neuromuscular neurologist who's interested in myasthenia gravis, and I'm also chair of the Department of Neurology at Virginia Commonwealth University. Today, I've got the great pleasure of speaking with a rising star of neurology, Jennifer Morganroth, who is a neuromuscular and EMG fellow at Columbia, but not for long, because she'll be joining the Healy Center at Massachusetts General Hospital to work on ALS and clinical trials next year. Jen is here to talk to us about her really interesting article in the Green Journal about trends and disparities in the utilization of thymectomy for myasthenia gravis in the United States. Jen, welcome to the Neurology Podcast.
Thank you.
I love this article in so many ways. I've often pondered about uneven utilization of thymectomy, and my sense is people do what their mentors trained them to do. And your data actually gives us some answers on this. And I wonder maybe before getting into the article, if you might give a bit of a primer on where things stand in evidence for thymectomy for myasthenia, and maybe tell folks about the MGTX trial briefly.
When I was doing this article, we looked a lot back at what evidence there was for thymectomy. And even though it's been being performed for non-thymomatous myasthenia gravis for over 75 years, there's really been no definitive evidence supporting its benefit until the emergence of the 2016 MGTX trial. And this trial looked at patients with prednisone only or getting a transsternal thymectomy with prednisone. And what it found is that it really did improve outcomes by not only reducing steroid doses, immunosuppressant needs, symptom severity, and also hospitalizations related to exacerbations.
Yeah, and obviously a landmark trial and a really hard trial to carry out. So a real accomplishment by Dr. Wolf and his team. I wonder if you could then tell us, what was your goal in this study? What was your hypothesis and your overall objective?
Since that trial in 2016, there's really been no population-based studies assessing thymectomy trends in myasthenia gravis. So our study aimed to answer two key questions. The first was to evaluate if the number of thymectomies performed over time has increased based on the trial results. And the second was to assess what disparities, if any, existed in thymectomy utilization.
What did you find? Tell us how many thymectomies were performed before the trial was published, typically, and then what did you find in the results?
We used the National Inpatient Sample Database, which includes 20% of all non-federal U.S. hospital discharges, and then we were able to use a survey-weighted analysis to estimate all hospitalizations in the U.S. And we found 218,000 myasthenia-related hospitalizations across 2012 to 2019. And we excluded around 6,000 patients on the basis of age and diagnosis of thymoma. And of the remaining patients, only 2% underwent thymectomy, 57% being the transsternal approach and 43% being the minimally invasive approach. And then what we found at 2012 at the start of the thymectomy is that only 45 were performed in 2012, and this increased to 1,150 in 2019. Those combined both approaches.
That's absolutely staggering on both numbers, right? 45 is crazy low. I just wonder, looking back, were you surprised by that number? I certainly was.
It's interesting that in 2012 to 2014, there was a modest increase, but then from 2015 to 2019, there was a massive uprising of the number of thymectomies, which really aligned with the MGTX trial. So I would just wonder if people just didn't have evidence to support that practice until this trial really showed good results, especially maybe in preliminary conferences.
So that, 1,000 is a really big number, but what percentage of maybe incident cases of myasthenia or patients with myasthenia had a thymectomy? And to give us a sense of the denominator in the data set, you said 200,000 plus hospitalizations, but there are 1,000 thymectomies or 1,150 in 2019. Out of how many patients?
For the thymectomy group, there was 4,430 patients, and the no thymectomy group was 209,000 patients, around that number. And then from that 4,500, about 2,500 got the transsternal thymectomy approach, and around 2,000 got the transcervical or VATS or more minimally invasive approach.
So it sounds like, huge percentage increases year over year, but as a percentage of patients who would likely be eligible, what do you think? It seems like maybe a little bit low. Obviously, you can't tell from the data set how many are antibody positive, how many were, presumably these weren't just ocular myasthenics, but still seems like a pretty low percentage of patients getting a thymectomy. Is that true, do you think, or am I misreading it?
I think it's still a low number. I think for our point, we looked really only at acetylcholine positive patients.
Oh, you did? Okay.
Yeah, it was only acetylcholine positive patients, like it was similar to the trial. And these were looking at all hospitalizations of myasthenia gravis and of those who got thymectomies in that population. So I think over time from 2012 to 2019, we probably captured more myasthenia hospitalizations because the database got better at picking up that diagnosis. And then a lot of patients with myasthenia get hospitalized for exacerbations for other reasons. So we're really just picking up the group that went in for the actual procedure in an elective type way.
Said that it takes 17 to 20 years for a new therapy to really impact clinical practice. And this level of increased utilization is extraordinary. It got me wondering whether you think there might be other contextual variables. The other obvious thing going on at this time in myasthenia has been an explosion in therapeutic development that was beginning right around this time, right? Do you think that that's raised the awareness of thymectomy? How on earth do we see this dramatic rise? 68%, I think, year over year, sustainably during this time period. It's remarkable.
Possibly, although I think it's a little unclear exactly what drove the increase. And I wonder if these steroid-sparing immunosuppressant agents might actually reduce thymectomies over time as more non-surgical alternatives to prednisone become available. So I'm curious, after this, with all these new complement inhibitors, et cetera, how this will change thymectomy utilization with time.
Wonder if you could talk a little bit about predictors of access to thymectomy. There's a lot of interesting information and I think some important lessons there.
So for disparities or what drove thymectomy utilization, we looked at both patient, hospital, and demographic level factors. And what we found was that there were definitely disparities in thymectomy utilization, with African American patients being 60% less likely than Caucasian patients to undergo thymectomy. And women were also 25% less likely than men to receive thymectomy surgery. And we looked more into this, and these disparities weren't tied to disease severity, which really highlights the potential bias in treatment access. And these also mirror trends seen in other surgical subspecialties like cardiovascular and orthopedic surgery.
What about rural populations, or you looked at academic, non-academic, large cities? What did you find in those data?
Yeah, so for the hospital level factors, we found that medium and large hospital sizes and urban teaching hospitals were all more likely to perform thymectomies than smaller hospital sizes and rural teaching status. And our thought around this was likely due to maybe having surgical availability or having a thoracic surgeon who was trained in thymectomy utilization. Although, again, this is just an assumption we made based on the data we found.
I've always had it in my mind that we're more likely to use thymectomy if we trained at a place where a lot of thymectomies were used. And I think prior to the MGTX trial, there was a lot of variability in the frequency with which folks would do a thymectomy. I don't know that you could really get at that very easily with this data set. What about geography? It was pretty evenly distributed across the country geographically. Is that right?
And there was no difference between the geographic locations, at least that what we found within our NIS database set.
What's your advice on how to think through these disparity issues, right? Do you have words of wisdom or ideas about next steps in terms of how we can think this through and make sure that there's even and appropriate access to this treatment?
Yeah, so when I was looking through the data and other research, I found that within a survey that most patients who underwent thymectomy had a conversation with their doctor about it. And those who said that they didn't undergo thymectomy was due to the fact that the doctor never had a conversation with them. So I think this really highlights the importance of the patient-doctor relationship and being sure that doctors at least explain the option of being able to undergo thymectomy if you had myasthenia without a thymoma. The other thing I didn't mention with the disparities is that older age and higher comorbidities were also less likely to undergo thymectomy, which we also see in the MGTX trial, with the age greater than 50 being a population that wasn't really looked at. So I do think age is something that we still need to factor in as whether that population is a good candidate for this therapy.
It does seem in your data that the trend is clearly towards minimally invasive thymectomy. What advice do you have to the extent that they're participating in choosing the surgical approach, whether transsternal, transcervical, good idea to use a robot? What are the sorts of questions? Do you have thoughts there, or just go with what the surgeon is most comfortable with?
I think when we were looking at research around this, obviously the point of the transsternal was to try to remove all the thymus. So that's why they used this transsternal approach, to make sure they got most of it out. But there's new research to suggest that these newer techniques like transcervical VATS, robotic assisted with 3D availability, is having similar outcomes and also offer less post-op pain and faster recovery, as well as lower morbidity and better cosmetic outcomes. So while there are no randomized trials, I think that I would still probably go with what the surgeon says, but I do think these minimally invasive techniques are probably equivalent, at least right now, to the transdermal approach.
Yeah, it's pretty exciting because I was always trained not to use anything other than transdermal because of the reason you talked about. There would be thymic rest or residual tissue throughout the mediastinum, and you needed a very experienced surgeon to kind of root around in there and find it. And so it's actually really great to hear that there's data suggesting that minimally invasive surgery is effective and safe for patients. What's the one thing that our listeners need to remember from our conversation today?
The main point of the objectives of our trial showed that thymectomy trends are increasing over time, with the minimally invasive technique outgrowing the transdermal approach. And the second, that disparities in care exist, most interestingly among women and African American patients, especially in the women group, who are more likely, especially in the younger bimodal population, to have myasthenia than men. So I think it's really interesting that that group in that population is less likely to undergo thymectomy, which really needs to be explored further.
Yeah, and unfortunately not, as you point out earlier, this is not a unique finding to utilization of thymectomy. So I think there's certainly a larger issue here we all need to be very aware of. I'll close by congratulating you. You've got quite the start to your career. You did this work while you were a resident at the University of Pennsylvania. You're getting your training at Columbia and off to MGH. So congratulations. This is a great story, not only because of the article, but because of your career, and I think inspiring to early career neurologists and residents and students hearing the podcast. So thank you for sharing your work with us.
Yeah, you're welcome. Thank you.
This has been a fabulous discussion with Jen Morganroth about her article on trends and disparities in utilization of thymectomy for myasthenia gravis in the U.S. A lot of lessons regarding the role of thymectomy and also some words of wisdom and concerning data regarding healthcare disparities. Be sure to check it out in the Green Journal.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.